guys, welcome back to the channel, and today's video is gonna be about newborn jaundice. So newborn jaundice. Newborn jaundice is one of the most common problem in the first week of life. It is known that approximately 60% of the term newborns develop jaundice in their first week. So now what is jaundice? We all know that jaundice is yellowish discoloration of skin and mucous membrane. But what is the difference between the jaundice in a newborn and the jaundice in an adult? In an adult, the jaundice is almost always pathological. But in a newborn, the jaundice can be both physiological and pathological. So now we have to know what are the differences between the physiological jaundice and the pathological jaundice. So coming to the definition, a physiological jaundice is something that occurs between 24 to 72 hours of life. It peaks by 3 days and it subsides by 2 weeks in a term baby. So what are the causes of physiological jaundice? The main cause is immature UDP glucuronide transferase, which is responsible for conjugation of bilirubin. The second is the immature Y ligand, which is responsible for transport of the bilirubin to the smooth endoplasmic reticulum within the cell so that conjugation can occur. And lastly, the sterile gut of the newborns, where there is no gut flora, which increases the enterohepatic circulation and thereby causing hyperbilirubinemia and jaundice. Now coming to the criteria for pathological jaundice, the first of it is any jaundice of greater than 5 mg per deciliter on day 1, greater than 10 mg per deciliter on day 2, and greater than 15 mg per deciliter from then on. Any jaundice that is seen within 24 hours of life, any jaundice that is greater than 15 mg per deciliter at any time after the birth. The rate of increase of the total serum bilirubin is greater than 5 mg per deciliter, and when the direct bilirubin is greater than 2 mg per deciliter at any given time after birth. So coming to the causes of pathological jaundice, the causes differ from according to a timeline. So less than 24 hours, 24 to 72 hours, and greater than 72 hours. So first, less than 72 hours, the most common cause is the RH and ABO incompatibility. Second being the intrauterine viral and the bacterial infections. And third being the malaria, and the last one being the glucose 6-phosphate dehydrogenase deficiency, that is the G6PD deficiency. In 24 to 72 hours, the causes include the sepsis, polycythemia, any concealed hemorrhages like the intraventricular hemorrhage, cephalohematoma, and finally the breastfeeding jaundice, which is basically increasing the enterohepatic circulation, thereby causing jaundice. Then after 72 hours, the causes again include the sepsis, neonatal hepatitis, any extrahepatic biliary atresia, the breast milk jaundice, and finally the Crigler-Najjar syndrome, which is a metabolic and inherited disorder. So what is the importance of learning about the jaundice and its treatment in newborn? Because it has got some complications which can ultimately lead to death of the fetus. So one of the complication is bilirubin encephalopathy, which is pathologically also called as kernicterus. So what is the most common site where this bilirubin encephalopathy occurs in the brain? It is basal ganglia. So there are different signs of bilirubin encephalopathy. Bilirubin encephalopathy can present as acute form or a chronic form. So in an acute form, if a child presents between 0 to 3 days, initially there will be hypotonia, there will be decreased inactivity of the child, and the child will have high pitch cry, which is also called as a shrill. If the child presents after 3 days, then the child will have hypertonia. The child also has retrocolis, which is nothing but hyperextension of the neck. Then the child will be in opisthotonous position. The child can also present with seizures and fever. In the chronic form, the child usually presents with extrapyramidal cerebral palsy. The child has sensory neural hearing loss and enamel dysplasia, which is nothing but the dental problems. So coming to the clinical assessment of the jaundice. So clinically, jaundice can be assessed by two different methods. Number one is the transcutaneous handheld bilirubinometer, where most common site it can be used is the sternum to measure the serum bilirubin levels. And then second one is the Kramer scale or the Kramer's rule, which is basically a visual assessment of a jaundice in a newborn. So in the Kramer scale, it basically states that the jaundice always progress in a cephalocaudal direction. So in a Kramer scale, we always divide the body of the newborn into different zones. There are 5 different zones. So each zone corresponds to a particular level of the total serum bilirubin. So let's see the zones. So the first zone includes the head, neck, and the basically which includes the eyes. It indicates the total serum bilirubin level of approximately 4 to 6 mg per deciliter. The second zone includes the trunk, which shows approximately a TSB level of 6 to 8 mg per deciliter. The third zone includes the lower abdomen and the thighs, which approximately includes or shows 8 to 12 mg per deciliter of the total serum bilirubin. The fourth zone includes the entire upper limbs and the legs, indicating approximately 12 to 14 mg per deciliter of the total serum bilirubin. And finally, the fifth zone, where yellowish discoloration can also be seen in the palms and the soles, which indicates TSB level of more than 15 mg per deciliter. So speaking about the management of the newborn jaundice, management includes both investigations and treatment. So investigations includes both the first line investigations and the second line investigations. So let's see the first line investigations. It includes measurement of total serum bilirubin levels, doing a peripheral blood smear, and matching the blood group of the mother and the baby. The second line investigations include a direct Combs test, which actually measures or detects the presence of antibodies on the fetal RBCs, measuring the hematocrit, G6PD levels, doing the sepsis screening, genetic studies to identify Crigler-Najjar syndrome, and finally the thyroid function test. Then coming to the treatment of the newborn jaundice, treatment is always in a stepwise approach manner. So once the baby is born, we observe the baby once in every 12 hours for the first 3 to 4 days of life after birth. So what do we observe first? So when we are observing the baby once in every 12 hours, initially we have to look for any serious jaundice. If there are any signs of serious jaundice, then we have to observe for any signs of bilirubin encephalopathy. If there are signs of bilirubin encephalopathy, then we have to immediately start the exchange transfusion in the baby. If there are no signs of bilirubin encephalopathy, treatment is still essential and we have to start the phototherapy. After starting the treatment, then slowly we have to send the blood for the investigations, and finally we can identify a cause and plan the further treatment according to the cause. Then if there is no signs of serious jaundice, then we have to observe for any signs of significant jaundice. So if there is any significant jaundice, again we have to send the blood for investigations, identify the cause, and plan the further treatment. But if there are no signs of significant jaundice, we have to continue observation of the baby for every 12 hours. As already discussed, we have two modes of treatment of newborn jaundice. Number one is phototherapy and number two is exchange transfusion. So in phototherapy, UV light is used to treat the jaundice in a wavelength of approximately 460 to 490 nanometers. So what is the mechanism of action? It has three mechanisms of action. The most important of it being the structural isomerization, where the bilirubin is being converted into the lumirubin. The less important one are the configurational isomerization, where the Z isomer is getting converted into the E isomer, and the least important one is the photooxidation mechanism. So there are two forms of phototherapy which we can use. Number one is the CFL, that is the compact fluorescent lamps, and the LEDs, that is the light emitting diodes. For the efficacy, LEDs are more efficient than CFLs, but more commonly CFLs are used in India. So what is the minimum distance that we should keep between the light and the baby? The distance should be at least 30 to 45 centimeters. We have to expose the baby completely except the eyes, which should be covered with an eye patch, and the genitals, which should be covered with a diaper. So what are the complications of phototherapy? It causes damage to the retina, which is why we are covering it with an eye patch. It causes damage to the testis, that's why we are keeping it covered with the diaper. It causes dehydration as it produces excess heat, and lastly, very rarely, the bronze baby syndrome. So we have to stop the phototherapy after at least two serum bilirubin levels are less than the cutoff, which are at least 12 hours apart. A short note on the bronze baby syndrome, it occurs when the phototherapy is given in a baby with conjugated hyperbilirubemia, and hence in conjugated hyperbilirubemia, we have to avoid giving phototherapy. So the second mode of the treatment we discussed is exchange transfusion or DVET, that is double volume exchange transfusion. So it should be given when there are any signs of bilirubin encephalopathy. Exchange transfusion can also be done in RH incompatibility when in RH incompatibility, exchange transfusion should be done at the time of the birth if the cord bilirubin levels are more than or equal to 5 mg per deciliter, if the cord hemoglobin levels are less than 10 grams per deciliter. So this exchange transfusion is usually done through an umbilical vein, and the most common blood group used is O negative, as it does not have any antigens. So then what is double volume exchange transfusion? It's something where we are transfusing the baby's blood with double the volume of the fetal blood, right? Okay, so finally a short note on prolonged jaundice. So a prolonged jaundice is defined as any persistent jaundice greater than 2 weeks in a term baby, and which is greater than 3 weeks in a preterm baby. So the most common causes include the breastfeeding jaundice and the breast milk jaundice. So in breast milk jaundice, in the breast milk there is something called as pregnanidiol, which interferes with conjugation of bilirubin, thereby increasing the unconjugated bilirubin levels and causing jaundice. In breastfeeding jaundice, it is basically due to inadequate breastfeeding. So when there is inadequate breastfeeding, it does not promote the gut maturity. There will be decreased gut flora, which increases the enterohepatic circulation of the bilirubin, thereby causing hyperbilirubinemia and jaundice. The other causes include the cholestasis and continuing hemolysis.